jaundice is some sort of a cellular problem. The examiner would then say to you, tell me a little bit about hepatitis and give me an update on the viruses of the hepatitis. You tell the examiner, we are concerned with the inflammation of the hepatocytes in the liver. So the 5 cardinal signs of inflammation are present. Carnage and heat and redness and swelling and loss of function and pain. And the viruses that are involved, well, we all know about virus A, which we used to refer to as ordinary infectious hepatitis. Virus B, virus C, which is sometimes referred to as post-transfusion type hepatitis. The delta agent, virus D, and the enteric form, virus E. They all exist and they all cause hepatitis. But before I go on telling you about these viruses in turn, perhaps I should just remind you that there are other viruses which cause hepatitis, and I was telling you that when I was telling you about the herpes viruses, the Epstein-Barr virus, infectious mononucleosis, in which the patients can become jaundice and febrile. So let's just now concentrate on virus A. This is a very small particle, 28 nanometers in diameter, and its genome is RNA, and it's not an enveloped virus. You can actually see the spherical particles underneath the microscope. So even though it's not an enveloped virus, it is extremely stable. And the proof is in the pudding, because it survives seawater and it can contaminate fish and therefore contaminate us in turn. Is it likely that you have had virus A? Yes, very likely, especially if you're from Africa. 25% of young people have had virus A. And if you are from overseas, that figure is much, much higher. We used to call it ordinary infectious hepatitis. Poor hygiene, contamination of food, poor sanitation, and that's how it spread. Is it harmless or is it harmful? Well, it's harmless long term, though patients at times feel desperately sick, desperately ill, and there is no specific treatment for it. Some patients get it much more serious than others. How do you know somebody has virus A? Well, you look for the appropriate antibodies, IgM, immunoglobulin M antibodies, and providing they're better, we can leave them alone. It hasn't got much relevance to the dentist, to the dental nurse, or in the dental surgery. So let's move on and consider virus B now. Now, virus B is a different kettle of fish altogether to that of the virus A. Firstly, its genome is DNA. Unlike the other hepatitis viruses, which are RNA, this one is a DNA virus. And is it serious? Yes, it can be. Mortality rate is reasonably high, 10% or so in epidemics, and not can it only produce chronic disease and chronic hepatitis. Patients can become chronic carriers without actually producing liver disease. And the risk groups, well, as I said, is spread by blood and by body secretions. But before I talk to you about the risk groups, I want to talk to you just a little bit about the structure of the virus. As I said to you, it's a DNA virus. So if it's a DNA virus, it must have the protein, the polymerase, in order to be able to replicate itself. And indeed, it has. So the DNA of the virus and the DNA polymerase are engulfed in the nuclear capsid of the virus. That in turn is covered by the core antigen. That in turn is covered by the early antigen. And then we have the surface antigen. Now, when the hepatitis B virus invades our body, it doesn't just target any old cell. It doesn't just go for your cardiac cell or for the neurons. It has specificity against specific receptors on the hepatocytes. And it binds itself on those hepatocytes. And it enters the hepatocytes via a process known as endocytosis. Once the virus is inside the hepatocytes, alarm bells start to ring. We've been invaded. The hepatocytes are not just going to sit back and take this invasion. They're going to send virus-specific cytokines into the bloodstream, which in turn switches on the T lymphocytes. The T lymphocytes arrive at the liver with their big heavy hammer, but they can't get into the virus because the virus is inside the hepatocytes. So they start breaking the hepatocytes in order to get to the virus. As soon as the cell wall of the hepatocytes is broken, the content of the hepatocytes are released into the bloodstream. One in particular are the enzymes. Alanine aminotransferase, ALT, and aspartate aminotransferase. And we can measure that. And we know that this patient is in acute phase of hepatitis B virus. And the risk groups, as I said to you, blood and body secretions. So hemophiliacs, because of factor VIII, that has stopped now, because blood is routinely tested and the positives are thrown out. Again, blood and renal dialysis. Patients and staff are at risk because of contaminated syringes and so forth. Again, blood and intravenous drug abusers. Again, because of contaminated syringes. And if you've been abroad and you've been in labor or you've had a road traffic accident and you've had transfusions in countries where they do not routinely test the blood, you can pick it up that way. And also in institutions. Mentally handicapped institutions where hygiene, for some reason or other, is poor. And semen and prostitution, and semen and homosexuality, and semen and heterosexuality. It's not a disease of dentists, doctors, and health workers. And that's how it all fits together. Blood and hemophilia, blood and intravenous drug abusers, blood and blood transfusions from abroad, blood and dialysis, semen and homosexuality, semen and heterosexuality, semen and any kind of sexual activity where there is an exchange of body fluids. How do you know somebody has virus B? Well, you look for the surface antigen. Remember the structure I told you about? You look for the hepatitis B surface antigen. There is something else you look for though. That's right. The little e antigen, the early antigen. And why do we do that? Because it tells you whether the patient is infected. So the examiner will say to you, how do you know this patient has virus B and is a danger to you? You say to the examiner, I look for the surface antigen, the hepatitis B surface antigen, and for infectivity, I look for the little e antigen, the early antigen. So let's now concentrate on the viruses which we call the non-A and B, and the first one is virus C, very similar to virus B in that it has the same risk group and the same complications, even more so, because it is reckoned that 50% of patients with virus C go on to develop some sort of chronic disease. Worldwide, it is a very important cause of cirrhosis. It is sometimes referred to as post-transfusion type hepatitis. Let's now concentrate on the other virus which we call the non-A and B, and that is virus E, found in Asia and Far East. So you say to yourself, it's harmless, and indeed it is harmless unless the patient is pregnant, where there is anything but. So there are two pairs, very similar, very much like each other. A and E fit very well together, and B and C fit very well together. So if you remember A, you remember E. If you remember B, you remember C. So where does D come in? D stands for the delta hepatitis. And the importance of this is that it's an incomplete virus. And it can only exist where another virus exists, and that is with virus B. So you never find D by its own, you always find it with B, and if you have a joint infection, that's really bad news. It can occur acutely, or it can occur chronically. That is, somebody with virus B can pick up virus D, and as I said to you, if that happens, if you get a joint infection, that's very bad news. You can develop chronic disease much more rapidly and could very well die. Virus B and virus C are also known worldwide for their neoplastic complication, which we call hepatoma, a malignant tumor of the liver cell. Don't forget, there are other viruses which can cause hepatitis. And I told you that when I was talking to you about young groups of people, 10 to 20-year-olds, that would be the glandular fever, the Epstein-Barr virus, infectious mononuclear